So I've pressed the button. It's saying going live. You're live, it says. So we're live, Gandhi. Good morning.
Hi, everyone. How are we doing? And welcome to this episode of our digital primary care update from the EGP Learning Podcast team. I'm Gandhi.
And I'm Andy. Hello.
And today we're going to be talking about a couple of things that are quite topical right now. So we've got a news story that's going to be our main kind of topic, and that's talking about care homes, which many of you in primary care will be aware is been a really hotbed topic for the past week or two. In addition, we've got some interesting offers for you. So we're going to talk about a social media platform that I think is going to be really awesome for you to use. And also we've got a freebie as well, courtesy of Dr. Claire Thomas. So she's a colleague of ours who's created something that you can all use, and a few extra little bits and bobs in there as well, haven't we, Andy?
We have indeed. So, and Gandhi, so you've been up since when this morning?
I've been up since about 3-4 o'clock this morning. Yes.
So it's Eid, isn't it? So happy Eid.
Yes. So Eid Mubarak to everybody who are celebrating it today. I'm aware some people may be celebrating it tomorrow and things, but majority, hopefully, I think are today. So definitely Eid Mubarak. And we hope you enjoy this episode where we talk about lots of different things. So yeah.
Absolutely. So shall we dive into the news story, Gandhi, because that really frames the rest of the episode.
Definitely.
Shall I get this up on the screen? So let's do the old screen share on Zoom.
Mm-hmm.
And so all care homes successfully signed up with clinical lead after record GP uptake. So this relates to the letter from NHS England on the 1st of May, which asked primary care to ensure that all all care homes are receiving a weekly virtual ward round from primary care. And it's sort of signaling that it's been a big success, apparently. What do you make of this story, Gandhi?
Yeah, it's been an interesting one. So for those that aren't fully aware of what's happened, clearly because of COVID, primary care has had to significantly change. And one of the things that was originally planned, so some of you may remember from our episodes back at the beginning of January about the primary care DES, was about the extended care homes element of the DES itself. And that was then delayed to start till October. However, because of COVID and the significant impact that's put on obviously our population, but especially our care home population, NHS England have used some of their executive powers to bring that element of the contract forward in a slightly different version compared to the DES specification itself, but fairly similar to it. And basically to suggest the practice, or pretty much enforce the practice, that they have to do a weekly ward round of their patients and with an MDT approach. And if not, then there may be some things that they need to consider as a result of it.
Yeah, so it's been interesting, and we've been involved with the implementation of this letter in Nottingham in our roles of primary care network clinical directors, and it's been interesting. It's always dangerous to look at the comments on these stories on Pulse, but it's interesting. So a lot of negativity around this this story. Badgering, lies, and deceit mentioned by one commenter there. We'll take that off the screen now and come back to us.
Well, I think this is because of the fact that, so there's obviously been this announcement that 100% of care homes have now got a clinical lead, which effectively is a GP aligned to each care home. And I guess the question is, primary care was given roughly a time frame of 2 weeks to sort this out, which, as many people out there would imagine, that's a logistical challenge at the very least to do. And I think there is some skepticism from the profession whether or not that 100% claim is actually accurate. Now, clearly, this is what NHS England are reporting based on the information they have, they say, from the CCGs and that kind of stuff. So whether there's a communication issue or whether it is accurate, we don't know, to be fair. And I guess there is a fair chunk, like I said, of skepticism out there.
I think the truth is that I think care homes already had an existing relationship with a GP practice. All care home residents already had a GP. They had a named, all over 75s have a name, but everyone really has a named GP at a GP practice. They have a relationship with them. Care homes, well, certainly as far as I know, have had an open channel of communication to the GP practices. In theory, if at least not in practice, but well, in practice as well. Whether that's as good as they would have liked, I don't know. So
Yeah.
I think actually a lot of what was being asked for was actually already in place in terms of those relationships.
Agreed.
And the ability to have a weekly check-in available is not much of a stretch on top of those. So I think there was a lot of good relationships already there. There's also perhaps a political element to this. I'm just observing that as we sit here at the moment, the government is taking a lot of flack for what has happened in care homes in response to COVID-19. And one wonders if there was some element of fishing for a good news story around care homes. But I know we don't like to get too political on the pod blast, so maybe we'll leave that there and perhaps dive into the issue. It does raise a lot of issues, both about how primary care networks and GP practices and CCGs and ICPs will be looking after residents in care homes both immediately in the aftermath of this letter and COVID-19, and then from the 1st of October going forwards. And it's a really great area where technology can make a big difference, and primary care networks, for that matter, obviously. So shall we dive into the letter? Let's
definitely. So
in terms over.
So it has a few asks in the letter, effectively, and I think that's what we're focusing on, isn't it, Andy?
Yeah. So if we just scroll through, we've annotated roughly the letter. We'll just sort of talk to a few points, really. So point one is the concept of the weekly check-in or weekly virtual ward round, which I think raises a lot of interesting questions and challenges just around. Okay, how are you going to do that? What platform will you use? How are you identifying who you're seeing on the ward round? All sorts of interesting stuff, which it might be good to talk to, really. So Gandhi, is this happening already in your primary care network, or is this a work in progress for you guys?
So I think various practices are going to have different perspectives on this, aren't they? And I think the reason for that is, like you say, some practices have been doing this from a regular basis, either down to historic funding or current funding even. So there are some practices across the country where this is routine for them because they've been doing it for a while, either as part of their federated working or as part of the service that they offer to patients. And there are some practices who have been doing it as an additional fee. So having effectively a retainer to provide extra service to those care homes. So there is variety and a difference in terms of way things do. There are definitely some practices that haven't done this work before, though, because it's not felt to have been either needed or it's not been a focus of obviously their attention given the other challenges that the practices and the care homes and that kind of stuff may have had. So I think it's a variable picture. In our practice, whilst we've not had formal weekly reviews of patients, we tend to have 2 care homes in our local area that we've had quite close alignment with and close working with due to historic funding. So I wouldn't have said it was weekly catch up with them, but at the very least on a monthly basis, we would have, popped in and just said, how's everybody else getting on, and just, troubleshooting, should we say, when we may not have needed to, being slightly preemptive. What about yourself, Andy?
Yeah, like yourselves, because of the historical funding. So we've had historical alignment of care homes with certain GP practices in the city in our neck of the woods for a while. That was previously funded, then the funding was withdrawn, and that's a bit of a bone of contention, but the relationships remained. So yeah, I mean, we don't do a weekly check-in currently in the run-up to this, but we do have pretty good relationships and open channels of communication. So how the care homes normally communicate with us is they send us an email. We've got a pro forma. If they have any issues or queries, they send us an email, and that's kind of channeled and processed appropriately within the practice. And, we will call and discuss anything that needs to be discussed. These days, we've been doing a lot of video with them as well in the care homes with the staff and the residents. So we can perhaps talk a little bit more about that when we talk about platform. And so I think we've been, doing lots of the elements, at least of a weekly checkup, but not as a single event. I think we've got more open channels of communication.
Yeah,
I know a lot of people are saying actually maybe a weekly check-in is more efficient than having that open channel. If you batch all of that work into a single point in time, maybe that is more efficient. You get that information all together. You can plan. You're already on the telephone or the Zoom to them, or well, maybe not Zoom for clinical content. You're on the Teams or whatever you're using.
Yeah.
And maybe that's a more efficient way of structuring the care for that week. So that'll be interesting. So we'll be experimenting with that going forwards. I know we've had a slightly different solution in Nottingham, in that care homes already have a really good relationship with a geriatrician-led and nursing supported service. So in terms of a weekly ward round, that was already there really from that service. So GPs haven't had to step up any additional service at the moment.
And I think it may be worth sharing some of our historical stuff that's happened locally, because it is actually quite relevant to this topical discussion. So for those of our GP learners that remember when we did our PCN DES kind of reviews, the care home part of the DES was backed up by evidence from some of the Vanguard funds that happened about 2-3 years ago. And the historic funding that me and Andy have talked about in terms of the alignment of care homes was one of those Vanguards. So it's one of those studies that have been used to support the evidence for the creation of the elderly care DES element. And it's interesting because actually our criteria that we were given was that each patient only had to have a 6-monthly review. Now, that did mean that practices probably went in, relatively frequently, once a month or so. But in terms of the actual patient-based review, that was only required to be 6 monthly. And that's a completely different ask to what many have seen this to be, which is a weekly ward round review. Now, I think there has been some elements of clarification that doesn't mean that you have to review every single patient weekly, which clearly, if that was the case, that's a massive undertaking to do. And to be fair, many would argue unnecessary as well.
Yeah, not a good use of resources.
Definitely. But I think it's important to recognise that the ask that's currently being done is different to some of the evidence that goes into it, shall we say.
Yeah, I remember the Nottingham service said it was a 6-monthly health review, but you did have to do a ward round every month for care home residents and every 2 weeks for not for residents, for the care home, and every 2 weeks, I think, for the nursing home. So it did have that element of review. It's interesting. So our scheme formed part of the evidence to support the new enhanced service for care homes with primary care networks, but our service was cancelled because it wasn't felt to deliver from a cost effectiveness.
Yeah, so that's the second part.
Wasn't that interesting?
It was felt by the local area not to be cost effective. And as a result, then we had the new service, which was geriatrician backed nursing led support to care homes, which has been positive. There's also been some negatives, and I think a lot of that's been around communication, but we're hoping a lot of that gets ironed out with the new methods that we're looking at exploring moving forward. But definitely, I think it's interesting the comments of evidence being used to support a lot of the change that have happened and how that works really.
But nonetheless, we're gonna be funded. There's gonna be £120 per resident, per bed, not per resident, and that is hopefully going to be in addition to those community geriatrician and nursing services that we at least have in Nottingham, and that can only be a good thing for the care of the care home residents. So I'm quite excited about the new service. Let's not talk about January, but I'm glad that it was changed from what it was in January and that it's now funded. So I'm actually much more sort of excited and relaxed about it and raring to go. Funded from October though. So this new, the new requirements from now until then, is that funded?
Well, this is an interesting point, isn't it? Because the comments have come through that you may apply for the funds to be available through the COVID element of work that practices are having to do. But that's not a guarantee.
I'm skipping to the bottom here. Yeah, it's this word may, isn't it? Additional costs for what we're being asked to do may be eligible for reimbursement from the COVID-19 fund. I know.
And this has unsettled a lot of people because whenever you put a maybe in, there's always the perception that means a no, or at the very least, if it's a yes, that there's significant amount of bureaucracy that comes with it. And we're already seeing that with some of the COVID claims that practices are having to do for the work they've already done to make practices and areas ready for managing COVID-based patients and things. So Andy and I have led on and the creation of clinical management centres, and the funding for those are still being worked out, despite the fact the returns have been submitted, several weeks ago, because it's just the bureaucracy that comes into it. So
Gandhi, let's dive in and talk about some of the technological elements of this.
Nice little sidetrack there, Andy. Yeah.
Well, it's so easy to get bogged down with
it is,
with the politics, both national and local, because these are really hot issues, hot areas. So you're going to do this in your primary care. Well, are you going to do it in your primary care network? Maybe you'll be doing it at a larger scale, but you're going to be doing it weekly check-in. What does this look like in a sort of best technology, best practice sort of sense? How would you design these weekly check-ins?
Okay, so I think the simplest way of doing it is simply it's a phone call to the care home to say, how are you getting on, and is there any support that you need, particularly with certain patients, and let's go through that. I think that's the simplest way of doing it. If you're looking at having a little bit of resource and backing and that kind of stuff, then clearly there's the opportunity to use other elements of medtech to support you. So video consultations is a quick and easy win, because it means you don't have to physically necessarily visit every single patient, and particularly with COVID being a concern, that's definitely an important thing. But also it gives that reassurance, I think, to the care home workers, and that you have actually seen the patient, because often there is this perception that if you just speak to them on the phone but you've not seen them, well, you still need to see them. Now,
there's something quite helpful for care home staff about that, isn't it? And it's about when their responsibility ends and has been passed to you as a more senior carer and clinician. And they always used to have a hard time with that on the telephone, feeling that you were taking responsibility for a decision when you are. A telephone consultation is a consultation, but there seems to be something a little bit more robust, magical, I don't know, different about video that means that they are more relaxed, that you've seen the patient, not just spoke about them. Sorry, just that I come in there, but video seems a key part of that.
And I think one of the other things for many people to remember is that one of the challenges that people have with video is obviously the tech not working. Well, you're trying to have video consultations with a population who themselves may not be able to do it, but have the support, like you said, of the care home workers. And generally speaking, most of them are pretty tech able. And I know in your areas, you've had some good examples of them using devices, haven't you, Andy?
Yeah, so we did this before May, right at the beginning of the COVID crisis. We had to review, a lot of care home residents quite quickly from end of life planning point of view and so forth, at a time when it probably wasn't practical for us to go into the care homes. So we had a conversation with our care homes, and actually the three main ones, we've actually been able to do video consultations quite frequently with them. One of the care homes actually didn't have any additional devices, wanted to get going quickly, and they've allowed their staff to use their devices to communicate via AccuRx. And given COVID situation, emergency situation, we thought, yes, okay, we'll do that. We've been told that none of the data around the conversation persists on the device, that it's the same as a telephone call to all intents and purposes in that respect. And they were willing for that. So we've done that. And maybe there's some grey areas around the governance that I think they can be overcome. It's been really effective, and it means that most of them carry their mobile phones at work, it seems. I don't know how their employers feel about that, but you can quickly go from being on the telephone to them to having a video consultation with a care home resident really, really quickly. So we found that quite successful, actually. Gandhi, I was going to ask you a question. So the legal significance of what it means to see someone on video compared to in the flesh has been clarified, hasn't it, recently by the letter from certainly from our local coroner clarifying it to us, and that's obviously come from higher up in NHS England. So there's a greater sort of legal weight to seeing someone on video now.
Yes,
you can complete a death certificate having seen them on video rather than seeing them in the flesh. Do you think that's going to stay?
Well, I guess just to expand on that for some of our lay listeners and stuff. So in terms of this, there have been requirements that in order to do a death certificate, the clinician, the GP, had to have seen the patient within the past 14 days prior to death. And that was always a physical viewing. Video wasn't always considered acceptable. There was some local variation, but the recent information because of COVID has clarified this to mean that actually that is acceptable. Now, appreciate that's a slightly morbid discussion to have, but in terms of impact for relatives and to be fair for the patient as well, if these changes hadn't come into play, then there was a considerable impact this would have had on the services, but also the chance that some people may end up having post-mortems unnecessarily just because of bureaucracy, which is clearly never a good place for us to be in. So I think the fact they made these changes is very considered and appropriate. And yes, I think it's given a bit more weight to the fact that video consultations are appropriate to be used, particularly if you know the patient. That's the key thing. I think it does make a difference.
So Gandhi, we've just had a question from Steve Katibe. Hopefully I'm saying this right. Katibe on the chat, which I think brings us nicely into sort of another element that we were going to talk about actually.
Yeah, so we've talked about stage 1, which is telephone. We've talked about stage 2, which is video. Stage 3 is then what do you want to do if you need to do some sort of monitoring or examination?
Yeah. So Steve, I'll read. I'm going to give him credit for reading his comment. So he said, "Hi, what happens if you need to examine the patients? Have you been doing that?" And so my short answer to that is yes, we have been going out. We've been going out a lot less than we were previously. Actually, I think everybody seems to be more, including the care home staff, seem to be more focused on limiting unnecessary contacts. And it's just interesting how fewer contacts we've had, whilst still, I think, managing the patients fairly effectively. But there have been times when I've gone out in my PPE, wearing my mask. I consider myself the main risk is me going into the care home, because I've been operating in environments where I have had exposure to COVID, but I have been seeing patients. But there may be other ways than us going out. So Gandhi, any ideas for remotely?
So your bog standard simple one is just to have some equipment in the care home. So obvious ones that we would think about, obviously thermometers, easy to do, and care home staff could easily take a temperature and often do. A SATS probe. So, not necessarily that the care home members of the team have to, do much apart from pop it onto the person's finger, and a blood pressure machine. And those three things will give you a variety of metrics that for majority of consultations, for particularly urgent issues and things, you would be relatively capable of doing things. I think where there's additional options is when you want to have more of the involved kind of examination stuff. So if we're thinking about things like otoscopy, as well as fundoscopy and the stethoscope, which, considered the key doctor tool and things. But if you need to have a listen to somebody's chest, how are you going to do that? And I think there are options out there to consider. So things like Bluetooth stethoscopes that allow you to transmit the sound from the digital stethoscope into a telemedicine solution, can allow that to work. And you could potentially use the care home staff or the nursing staff, particularly in those care homes, to help assist you in the examination of the patient, doing it remotely because they're there with the patient. Alternately, you can use systems designed to give you all of that in one, and they're awesome. So a couple worth mentioning. So one is something called the Techie Hub, and the other one is something called Medic Spot. So these are two kind of systems that give you the whole kind of kit that allows you to do some of this, and therefore as a result of that, you can do everything all in one.
Good. And I know something that your primary care network were exploring before, which I think has gained a bit of a new relevance now. You were thinking about a visiting service using, say, a physician's assistant or another person who could be trained to use some of this remote monitoring equipment or do slightly more complicated physical examination like auscultation of the chest, and feed that information back to a more senior clinician who's supporting on video. And I think that, I can really see there was a place for that in the future before, but that's sort of taken on a whole new relevance with the increased use of remote technologies going forwards. Because a lot of the time, you could use a digital stethoscope, you could route that sound back through to the person listening in the doctor's office, but it's the positioning of that equipment and so forth, where you need someone who knows how they're doing it. So having somebody who is less expensive, resource, could do the travel time and do that. So I think we'll see more of that going forwards.
Well, I think there's also the element of, like I said, trying to enable the care home staff and even the patients to do some of this themselves, because actually a lot of it is just about guided principles of where to place things. And if you can do that, then actually, do you even need a clinician to go out and do some of that for you? Maybe not. It does. Obviously, there's individual patient situations that come into play with this.
Yeah, but you're right. But carers and nurses in care homes would be a really useful resource to train how to do some of this stuff. So I'm gonna think about moving us on. So, Gandhi, so we've been talking so far about, okay, what happens up to the 1st of August.
Yeah.
And we don't have to design the 1st of August yet, October,
yeah.
For the main enhanced service. But when that comes in, there's going to have to be more coordination between the different components of the MDT. So we're talking about sort of virtual MDTs and these sorts of things.
Yeah.
We've talked a lot about virtual meetings, and I suppose it is essentially a video meeting that we're talking about. In terms of what platform and how, had you begun to have any thoughts about what might work well?
Yeah. So I think the easiest one for many practices and networks to consider is going to be Teams, just because of the national offer that every GP has been given in terms of using Teams. Now, one of the concerns I think many people have about using Teams is partly it's the 3-month offer, and the fact that it's not the, shall we say, and I've used the term before in some of our stuff, the full fat Teams. Effectively, it's a stripped down version of it, and therefore that does limit some of the ways that you can use it effectively. But the benefit of Teams is that it's a collaborative piece of software that allows you to do the video consultations, allows you to do the cross asynchronous discussions and the file sharing elements of things that would allow you to do a virtual MDT without any real difficulty. And it's certified for patient information use as well. And that's the big one. It's the fact that you can talk about patients, unlike Zoom, which, although me and Andy love Zoom, we completely recognize that doing patient specific data via it is probably not a great thing.
Yeah, no, absolutely. I agree entirely. I think Teams is probably what people will gravitate to. Also, I think Teams is likely to be more universal across the different elements of the MDT. So in Nottingham, we'll be looking at perhaps a GP-led element, which will probably be run through PCNs or the group of PCNs across the city, which we might get to in a minute. But then we've got a nursing element, which is run by City Care. I'm not quite sure who's funding the geriatrician element. That's either City Care or it might be through NUH, our local University Hospital Trust. But I think all of those people will have NHS email addresses and Teams accounts. And they will probably be using that within their own organizations by October. So it shouldn't be too much of an ask to get them all coordinating with Teams. If we were to try and get people to use Zoom or other platforms, I think that might be more of a challenge. So I think Teams will probably just have that network effect, that center of gravity to pull people towards it. Gandhi, how are you going to coordinate them? This might be too early for this, but I think there's all sorts of challenges running MDTs that could be solved via using a virtual platform. You're getting rid of the travel issues. So that means people can do elements of the MDT in between doing more other things. Not every patient that's discussed at an MDT is relevant for everybody who might have traditionally attended the whole MDT if they were traveling there. So there's a whole coordination piece where if you get it right, you can use less of people's valuable time to complete an effective MDT. I also wonder if some things could be done asynchronously. Just like we fire off a little dictation letter, or we used to type, as a quick way to get something out of our mind and summarize what we've just done. I mean, could people do video or audio depositions to the MDT? There's so they don't even have to be at the MDT to be at the MDT. All sorts of possibilities. Maybe they're just ideas and possibilities at the moment. Any thoughts?
Well, I think there's some logistical elements that many people are going to have to consider how they do this moving forward. And what I'd be really keen to do is actually hear from some of our EGP learners who've already done this, because we know of areas where they've been doing this kind of work already. I guess if you're going to ask me how we're going to look at doing it, so obviously from our perspective in Nottingham, we're looking at having a slightly broader approach to this in terms of how this works and working cross-network in particular to try and provide a system at scale that works for the whole area. But in terms of the individual clinicians that are doing this, so if you are having practice-based leads, you have to have the opportunity for them to dial in at a certain point with the rest of the MDT meeting. Now, could you do that completely asynchronously? Yes. But how is that going to look from a workload perspective for that individual in terms of dipping in and dipping out of that particular role? Because there's the danger that it bleeds over and that you're having to do a certain amount every single day. And if it's structured that way and that's how it's planned, fine. But it's that element of it could become something that you're having to constantly check, and that whole always checking your email element of things that many of us have fallen into that trap of doing may become a part of the reality, and then that's not a good way of doing things, I don't think. So I don't know, we've talked about this before, haven't we, Andy? Batching the work and making sure that the structure for batching the work is done to make it sensible and achievable, really.
Yeah, I think it feels like there's a lot of work and a lot of thought to be done around good virtual MDTs, and I'm sure it's a topic that we will return to in the future because it's going to be big, not just for care homes, but for all sorts of other areas, and not just primary care, secondary care too. So shall we return to the letter and just see what else we've picked out?
I think it's worth talking about the MDT itself, isn't it? So this is one part that is a requirement from October, definitely, and it's a suggestion from currently, so to try and include your MDTs. Now, locally, we, like I said, have an offer of the care home work being done funded by the CCG, and that's geriatrician-led nurse covered service. And that effectively supports our MDT working with the practices already. I think key things that need to be resolved from that is communication, to make sure that everybody is aware of how that works. And it also feeds into this whole concept of online consultations as well, not redoing everything just for the sake of redoing it. So if you've got a really coherent, competent set of notes from a nurse who's just been out to see the patient, do you need to then go out and do the entire history and examination all over again when it's just documented in the notes and you can see it? Probably not. You know, and using that mechanism, that way of thinking, rather than just assuming that, oh, I'm going to have to go do it again because the patient's unwell, and actually you probably don't. But there is a trust element that comes into play with that, isn't there?
Yeah, absolutely. And that's easier if you have more knowledge about that clinician or you've engaged with them. So if it's someone that you speak to at an MDT, I've found I'm much more inclined to not feel that I need to repeat any of the work or examinations or questioning that they've done. If it's just a few lines in system one and you've got no idea who they are, and particularly if they're suggesting that you do something, that they may think this person has cellulitis and that it may be a good idea to give them some antibiotics, for example. I find that if I know the person, I've spoke to them before, I'm much more inclined to trust their assessment than if it's just a random message coming through from a service, which I often will do and execute, but it sometimes leaves me feeling a little bit vulnerable, sort of clinically.
And it's also the level of information they're sharing. So if they're giving you that request and that they've documented that the skin is erythematous, that it's uncomfortable, that they've got potential mild temperature, and they've put some images on there as well to give you all that information, well, how much additional elements are you going to get by reviewing the patient yourself face to face? Probably not. Whereas if it's just, can you prescribe antibiotics to the patient I think has got cellulitis, and no other information, then you're going to feel a bit uncomfortable with it, aren't you? And you're going to potentially want to review that patient again, which is a complete waste of everybody's time.
So that's setting some ground rules, isn't it, about the quality of information moving within the MDT. So that's an area to look at, and standardizing how the information moves and what you need to know to do a certain action. Interesting times. So Gandhi, a hot issue, you might have been about to say something else there. I was going to move us on to alignment. Because I think that's a hot issue locally. There may or may not be technological elements or solutions to that. I'm not so sure. But so in the letter, CCGs are asked to ensure that care homes are aligned to primary care networks. And I think that's the ask essentially within the letter and for the LES, the enhanced service. And who looks after care home residents and how many are looked after by each practice in a network or an area can be controversial. Have you had any experiences of that in your primary care network or around Nottingham?
Yes. So, I mean, there are different perceptions of how this has worked effectively. It's important to remember, I think, that, alignment of practices to care homes and networks to care homes seems like a sensible idea. And I think doing it from a network basis is probably more sensible than doing it from a practice basis, just because of one of the things that people sometimes forget is that where there tends to be most care homes is where land is cheap, because just simply logistics, trying to afford a large piece of property, it tends to be in cheaper estate areas. And as a result of that, that tends to be in the more deprived areas. and therefore they're more denser and there's more patients, and then that can lead to quite significant challenges where you will have some areas which have several care homes and you have some areas which have none or very few, and therefore that disparity of work is an interesting thing. And in terms of, I guess, networks, so if you would take my network, for example, fairly deprived area, we've got about 12 care homes in our network geographical area. Compare that to some of the other networks in the Nottingham City. Well, we're the second highest out of the 8 networks in our Nottingham City area. But even within that network, one of our practices currently looks after about 50% of the care home patients in our network, just because of the geography.
Yeah, absolutely. I mean, we've got two practices who probably look after 80% or so of the care home residents. You know, they've got well over 100, 120 care home residents each for these two practices, and the other practices don't have a great deal of the care home residents. And that's a historical feature from the previous enhanced service that we discussed earlier that promoted alignment with individual practices. But when it comes to the question of should we redistribute some of these residents, you know, some of these residents, obviously patient choice is paramount, but we're not living in a world that's completely driven by patient choice at the moment, because when a resident joins one of these care homes that has a historical alignment with a practice, they know that they are on the phone to that practice several times a week, that they can bring up queries. They've got an idea of their readiness to come and visit or respond, and they're just more inclined to register with that practice that they've got a relationship with already. So even though the enhanced service and the conditions that brought this about are gone, the steady state is still maintained that those care homes prefer to register with certain practices, and they influence the families and the patients when they come in to do that. So the question is asked, well, that's historical. We're doing it as a primary care network now. Should we redistribute new residents to care homes more equally? It's not always met with enthusiasm, those sorts of things.
And it becomes really challenging as well, doesn't it? Because for the practices that have a high amount of care home bed patients, they've probably spent time developing that relationship with those care homes to manage them, and do they want to give that up, and also create their services potentially to deal with that workload? So if that workload was to change, how are the practice going to manage the staffing resource that they built up to adjust to that? Similarly, for those practices that haven't traditionally had a lot of care home-based patients, they're now suddenly going to have to do additional work that they previously weren't having to do, and may not even have the necessary depth of skills in the practice to manage that, in comparison to some of the other workload challenges that they may or may not have. And then you get into the really fun part, which is looking at it's not just from a cross practice boundary, and potentially not even from a cross network boundary, but then if you go even wider across, ICP or CCG areas, what do you do when a care home is literally on the border? Which way does it go? How does that alignment work? And it's a real challenge, isn't it, Andy? I mean, I can expect there to be some serious bun fights happening about this.
Yes, I think so. Fortunately, it's the responsibility of the CCG to ultimately make these decisions. So it's not beholden to primary care network clinical directors, although we've been asked to be involved in some of the discussion, haven't we?
Definitely.
So it's interesting. And I suppose that just brings us on to the scale at which you tackle this, which you've alluded to. So I suppose at the one end, so there's going to be £120 per patient to be spent on the GP element of
per bed, Andy.
Per bed.
You're right. Yeah, per bed. You do.
Per bed. I think the old one used to be per patient. So per bed. And you could do this in a number of ways, couldn't you? So you could just say, well, they're all patients at beds. Care homes are already aligned with a practice. Why not just give all of the money to the individual practice to deliver that service at one end of the spectrum? And at the other end, you could say, actually, let's several primary care networks. So in Nottingham, the city is geographically the city. There's 8 primary care networks. We could say, actually, let's pool those resources and have a cross-city service that aligns with the other services which are already structured across the city in the same geography, and deliver the requirements that way. Or I suppose there's something in the middle where the primary care network employs additional staff itself and delivers the service. There's pros and cons really to doing it on all these sorts of levels, and I'm sure we'll see different models emerging in different places in the country. What do you think would work for us, I suppose, or another area?
Yeah, so I think you're right that there's various different models that can be looked at. And I think the key thing is looking at your individual characteristics, resources, and support. I think for our Nottingham City area, I think many of the clinical directors, and I know me and you both feel this way, that a citywide approach is probably going to be the most sustainable, because it does allow for some elements of economies of scale, and it does allow for an element of making sure that there's resilience in that system and capacity, but with that also making sure that there is that relationship for practice to be maintained with the care homes, because a lot of the practice has spent a lot of time, a lot of effort trying to look after these care home residents for several years and develop those relationships with the practice. And I think they also feel they don't want to just give that up, because it's an amount of work that they've done that has been a benefit. It helps these patients, because the relationship is often the key thing that can build trust and clinical care into how this thing works, isn't it?
Absolutely. And, it's important to look at it from that patient perspective, isn't it, as well? The existing patients, I'm sure, do not want to be realigned with new GPs at that point in time in their life when continuity is really, really important for their outcome and their experience of their healthcare. So we've just got to bear that in mind as well. Lots of things to juggle. Oh, just had a comment from Stephen again. This £120 per bed will be given to CCGs or directly to primary care networks. So my understanding is that it goes through primary care networks. So that's Gandhi's understanding as well, which is great. So no opportunity for a haircut there on the funds or anything like that. It should go straight to the primary care networks, then straight to the delivery of the service.
And it's important to remember that CCGs who are currently already funding existing services for care home work have been clearly told by NHS England that funding should not be cut or diverted to other areas. If they're spending that on care home residents, irrespective of what the networks are getting, that funding should still be used for care home residents. So it's important.
This funding should not be seen as an excuse to cut existing funding for care homes. I think that's really, really important principle to follow. So Gandhi, the last thing that we'd put on our notes to talk about with this letter, towards the end, it talks about NHS collecting SITREP data, situation report data. I think that means to monitor the service delivery. And I can understand why they want to do that. There's going to be some funding attached to it. It's important that they know that it's funded well. If you were NHS England, what would you be looking for? So I suppose they're going to be extracting codes from our GP records, aren't they? What would you be looking for if you were designing a way to monitor the quality and activity in the service?
Okay, so if I was NHS England doing this, I'd probably want to know how often a patient's being reviewed, what element of depth of review that has happened, and is there some data in there that I can present to my masters to present to say that we're doing what they're asking us to do. That is a slightly cynical view, I appreciate. But effectively, that's what they want. They just want to know that the reviews are happening. And I guess if you're looking at it from a health benefit, how is that improving the quality of life for these patients? So things like palliative care for these patients, things like mobility, those are things I'd actually be focusing on in terms of, the quality of life for these residents. So if I was to look at this, designing it from the ground up, wanting to do the best service possible, I'd actually be asking our practice to capture things like the frailty scores and looking to see if there's an improvement in those, looking at polypharmacy and seeing how that works in terms of the quality of life, the ACB burden, anticholinergic burden, which is a massive challenge for many of us, and particularly as you get older, because a lot of the medications that you may be taking may add to that. And we know as time goes on that that's a massive impact in terms of your quality of life. So that's actually what I would do, irrespective of what NHS England were meant to do. I guess I
think that's a really interesting answer, actually, because you're right. I think what they will do is look at how many structured medication reviews happened, how many health reviews have occurred, how many times patients have been discussed at an MDT meeting. I think they will be inclined to report on activity. But what you've just mentioned, I think, is probably more important, actually. And actually, perhaps you should be reporting on outcomes. Are these people, remaining healthy, mobile, living longer and more healthy into old age, because that's probably what really matters and would really matter to patients as well. But it's harder to demonstrate how the money is being spent, because the money is spent on activity, not outcomes. So I've just got a feeling they're going to gravitate towards the activity measures, and there's an argument for that, but I hope that outcomes are looked at. Also, I was going to say, there is an opportunity for primary care networks and cities to capture their own data, isn't there? You know, NHS England aren't the only people who can audit and report on things. So I think areas and primary care networks should, from the outset, perhaps design in their own outcome measures to capture some of this more qualitative stuff, so that they can demonstrate to themselves and their practices and their patients what the impact is. And also, if NHS England have an issue with anything, they'll have their own data to come back at them if that's necessary. Sorry, you were going to say something.
Yeah, well, I think it's one of the endemic problems with the NHS, isn't it? The NHS loves having quantitative data to present to justify the work that it's doing to the people that pay us, which is obviously the government, as well as our public, because effectively we are a public funded service. But the problem is that health is not a transactional element. You know, it's not something you can just put money in and guarantee an outcome. There's lots of grays, and you know, if you work towards outcome-based working, unfortunately, it takes longer. Like, for example, longer than a government cycle for that to be materialized potentially, and therefore that's why they don't like using that element of data, which is actually the thing that matters to people, the individual. So it's a real challenge to make that work, but it takes buy-in. I think one of the things that I hope that we will see in our Nottingham City area is that with the lead time we've got to having a fully functioned service from October, that some of that buy-in work will be done to try and get the understanding of, actually, if we're doing this, let's do it properly, and let's do it for the benefit of our patients, not just for the taskmasters.
Yeah. And in a way, the letter from NHS England about the care home check-in at least has brought it back into focus for us ahead of October. Yeah. And we'll probably deliver something better in October for having received this letter now in May, I suspect. So Gandhi, shall we begin to wrap that up and move on to the offers for the readers, for the viewers, the listeners, unless you've got anything more specific to talk to there that we've not covered?
No, I think it's just important to say that if people do want to check out some more information, obviously have a look at the show notes. We've got some of the links for the documents and stuff that we talked about, and share what experience you've got in your areas, because every place is doing something different. And we would love to hear actually really what other places are doing. I know there are definitely some areas that are doing some really cool things, and particularly from the health tech perspective, you know, if you are using kits to try and make this process work so much better. So, you know, we've heard about Techie Hub and MedicSpot and stuff. I also know about other kind of things like Think Labs One, the stethoscope that works through Bluetooth and things. But those kind of innovative ideas, those are the things we'd love to share with our EGP learners. We're more than happy to discuss those on future episodes as well. So definitely get in contact if those kind of things have, you know, piqued your interest and stuff.
Excellent. So thanks for listening and interact, as Gandhi said. Gandhi, you told us at the beginning that there was some potential offers or opportunities, and there's some videos coming up on EGP Learning. So walk us through those.
Sure. So a couple of quick things. So number one, as many of you know, I'm a massive social media nut, and I have a firm belief that practices that engage in social media are more likely to be successful. And particularly one of the things we've seen with the COVID happening, and particularly from a PPE perspective, many practices have engaged with their local populations a lot more effectively and meant that they've been able to function so much better. But doing the social media part of it can get really, really complicated, and it scares a lot of practices as well. I mean, I don't know how you feel about using social media from your practice perspective, Andy.
I mean, so we're quite comfortable with it. You know, I'd love to do one of these live sessions about social media, because I've got all sorts of conflicting thoughts on social media. But I tend to finding the people with the right skills to do it. That's the problem. If only some of my admin team could be upskilled in organizational management of social media, that would make life so much easier, because the doctors and the senior people often have the skills, but they don't necessarily have the time to do it. Any way of solving that problem, Gandhi?
Yes. So number one, check out some of our other episodes, and we will put those in the show notes. We can't ping them up right here, but if you're watching this on the recap, we can do. But we've got some episodes that actually cover how to use social media as a practice. And that's the key thing. It has to be done as a practice initiative, because relying on the GPs to do it, it won't work. And just leaving the admin team to do it as well, again, won't work. It has to be a collaborative thing. But one thing I would like to suggest to people, so over the past couple of years, I've been looking for a variety of tools to try and find one that works for general practice. And I think I found the one. So it's a tool called Publi. I do use it, and I have been using it for the past 6 weeks or so. And I find it really simple, easy, and effective to use. It allows you to do loads of things like batch processing of your posts, so you can post them and then have them scheduled to leave out at a separate time, which is a really useful way of managing your social media content. And it's got some really cool features like automatic deleting, short codes, and various other stuff. And it's got a roadmap that looks really attractive in terms of bringing more ways for that content to work moving forward. And for me personally, it's probably one of the better platforms I've found. And right now, it's at an absolute bargain price, I must admit. So if you're interested in this, have a look at the video that I go through it in more detail in terms of the platform itself. But for £36 for life, you can have the entire full fat Publi, which, normally this is £20 a month they charge. And you can have the access to that for life. And you don't have to pay anything more ever again, which for me is a bargain. And when I saw it, I instantly had a look at the platform, thought it was pretty decent, not regretted it. And I've probably saved my money several times over by the amount of time it saved me in terms of cross posting and all that kind of stuff that I do. And definitely as a content creator, yeah, awesome. Only downside, it doesn't do Instagram yet. But yeah, I don't think many practices are going to worry about that too much at this point.
No, definitely want to check out. And I believe you got something else to say about immunization.
Yes, so I wanted to give a shout out. Yeah, so I want to give a shout out to a colleague of mine, so Dr. Claire Marie Thomas. So she's a GP that I've forgotten which practice she works at, but she does lots of really cool stuff, and particularly work with Wonka. In terms of trying to help her local area, she's created a really useful little video packet to try and encourage patients to have their immunizations. And with her consent, actually, we put this on the EGP learning platform. So practices can use this video for free. You can either directly use it from the YouTube, or you can download it if you want to as well. And it's a nice short package that just suggests, why you really should keep your immunizations up, even despite COVID and all the other kind of stuff, and gives quite a lot of reassurance and stuff. The only thing she's asked that if you do use it, just tweet her so that she can kind of track how well it's being disseminated and that kind of stuff, but completely free to use. It's already out there. So it was released at 11:15. Have a look at it. I really like it. It's just short, it's snappy, and it's to the point, and it just makes, I think it'll be really good to engage with patients.
Awesome. And System 1 online summit.
Yes, so we've got a couple of quick announcements around this. So many of our EGP learners will remember at the beginning of the year, Andy and myself were gearing ourselves up to try and deliver a System 1 user conference to our fellow EGP learners, and this was working collaboratively with TPP. And then this tiny little thing called COVID came along, and that's kind of put a scupper to pretty much all kind of physical events. So we've been looking at how we can move this forward, and we're now looking at delivering an online event in the near future. Now, we don't have any more specifics than that because we've just had this agreed, but we are planning to do this fairly soon. And the main reason I wanted to talk about it with you guys right now is just that if there's particular content that you would like to have delivered, and it would be through an online mechanism, we're hoping to do the face-to-face conference, but that won't be till at the very least next year now because of obviously the current healthcare situation. Get in contact with us, just let us know. And yeah, we are keen to put this forward for you guys so that we can have something that we think will be really, really valuable to anybody using System 1 and its sundries.
Yeah, and Gandhi, you've been, I've been amazed by the amount of content that you've been able to put out over the past few months around online consultations, video consultations, and all of that. I think you've been doing a great service to us all by getting all of that out there. But I guess you want to ask us, what more do we want to know?
Yes, so this is in terms of online consultation. So one of the things I've tried really struggled with is that there's various different online consultation platforms out there, and they all do slightly different things, and they deliver a service to, I think, what the providers think that we want. And what we'd be really interested to know is what does general practice actually want? You know, how can we use things like online consultation, telephone consultation, video consultations? How could we actually use it better, rather than being led by what's currently provided for us? What things would make your life much better if it was part of it? You know, the aspirational, the blue sky thinking when it comes to the tech, what would actually work for you? And I'd be really keen to know that, because there's a potential that we can feed some of this information back to the providers themselves. So if you are able to do that, just simply wing us an email, egplearning@gmail.com. More than happy to get some of that and collate some of that information. And we will be hopefully putting out a survey shortly to get some more constructive information on that. But yeah, right now, just let us know. And you mentioned all that content. So lots of things are happening right now, particularly for trainees. In the next week or so, we're going to have some really cool content coming out specifically for trainees around things like the RCA and that kind of stuff coming forward. So yeah, keep tuned, because we've got lots of stuff coming for all of you.
Excellent. So that's almost a wrap up for our Saturday morning surgery on the eGP Learning Podblast. Hopefully people enjoyed the chat. Hopefully people found it informative and interesting. And there's lots of great content sort of queued up to come out on the eGP Learning platform. So I guess we're about to sign off. So sort of signing off from Andy. Gandhi?
Yeah, and sign off from me. And as always, guys, if you've got any comments or questions, contact us, whichever platform you prefer. As we mentioned, we're on all of them already. Definitely leave us a review. We love it when you do that. It makes us so much happy inside.
And subscribe. It's great to see the subscribe figures going up. Over 1,500 subscribers now, which is amazing.
Yeah, definitely shout out to all of you. You know, with today being Eid, we hit 1,553, which for me is a slightly auspicious number. So I was just ecstatic about that. Definitely ring the bell so you get notified of all of our content. And as always, eGP Learning is here to help save you and your patients time by tech enhancing your primary care and learning. And we will catch you in the next episode.
Yeah, goodbye. Enjoy your bank holidays, guys. Bye-bye.
You too. See you later.